we start, there'll be very little, no side talk, so we can.
I don't think so. Okay. All right, good morning and good afternoon to our friends in Nigeria. My name is Lauren Herzer, and it's my pleasure to welcome you to the Woodrow Wilson Center this morning on behalf of my colleagues in the Maternal Health Initiative. Today's event is entitled Emerging Priorities for Maternal Health in Nigeria. As many of you know, the Wilson Center is the formal memorial to our 28th president. In his honor, we tackle global issues through independent research and open dialogue to inform actionable ideas. Today's video conference is part of our Advancing Dialogue on Maternal Health series, which works to address many critical and neglected maternal health topics and is generously supported by the Maternal Health Task Force and UNFPA. I'm going to give a little bit of a background on the series, and forgive me for reading a script. It's just there's a lot of meat to it, and I don't want to miss any of it. The series began with the goal of raising awareness about the social, economic, and health system factors that need more attention in policy and programming, with special emphasis on critical maternal health topics that are often overshadowed by the resources and attention earmarked for reducing maternal mortality. To expand input from the field, in 2011, we partnered with the African Population and Health Research Center in Kenya to co-host a two-part dialogue series with local, regional, and national decision makers on effective maternal health policies and programs. The second installment of the series focused on identifying opportunities to maximize national responses to pressing maternal health challenges, such as environmental concerns and toxicities in pregnancy. Last year, we collaborated with the Population Foundation of India to convene a multi-sectoral group of stakeholders to recommend steps the government should take to reduce its high levels of maternal mortality in India, where 20% of the world's maternal deaths occur each year. This year, we focused on systems of accountability and monitoring and how maternal health will fit into the post-2015 development framework. We're thrilled to have partnered with the Center for Population and Reproductive Health to bring the policy dialogue to a high-level group of policymakers and practitioners in Nigeria in a day-long meeting held yesterday in Abuja. Today's discussion will highlight some of the insights and recommendations that came out of that meeting. In just a few minutes, Professor Oladosu Ojenbedi, Director of the Center for Population and Reproductive Health, will give us more background on their discussion. A quick note about today's meeting: it is being webcast live. So when we come to the Q&A session, please wait for a mic to be handed to you before stating your name and affiliation and asking your question. Our Twitter handle for today is #MHDialogueNG, in case those watching live would like to send in a question via Twitter. It's my pleasure now to introduce Sarah Craven, Director of the Washington, D.C. office at UNFPA, who will start us off with some opening remarks.
Well, thank you. I'm going to speak very briefly to just mostly say welcome, and I want to say welcome to Nigeria, where it's 3 in the afternoon. I don't know, Nigeria, if you can see us all. I'm waving to you. Can you all wave? Good morning. And here in Washington, it's cold, and we're drinking hot coffee and wishing we were in warm Nigeria. But I want to say on behalf of UNFPA how really thrilled we are for this partnership that is now in its 4th year? Yeah, entering our 5th year between the Woodrow Wilson Center, UNFPA, and the Maternal Health Task Force. This is a fantastic opportunity to have these dialogues. In addition to Nigeria today, we also have colleagues at the Harvard School of Public Health who are tuned in, as well as our colleagues in UNFPA in New York, UNFPA Geneva, and hopefully in other parts of the world watching this dialogue. So for me, it's just incredibly gratifying when we're able to share our experiences in such a through so many time zones and through so many miles through the power of technology. So I especially want to say thank you to Lauren and her colleague Sandeep over in Nigeria. And thank you so much. And I'm thrilled it's at the UNFPA office in Nigeria. So now we can say we virtually have seen where that is. And I'm going to turn it back to Lauren.
Thank you, Sarah. We're going to turn it over to Nigeria now, where Professor Ojenbedi will give us a brief overview of their meeting yesterday. Following the presentations from Nigeria, we'll invite John Townsend, Vice President and Director of the Reproductive Health Program at the Population Council, to respond, and then we'll have some back and forth. Okay, Professor Ojenbedi.
Yeah, thank you, Lauren. Okay.
I think we
lost
just
it?
had,
Oh, there we go. No,
Oh,
is it freezing?
Okay.
Can you hear us?
We can.
Are you? Okay.
Okay, great.
Okay, so thank you, Lauren, for I welcome our audience in DC and friends to this video conferencing. It is hot here, so we are drinking cold water while you are drinking hot tea or coffee. On a personal and corporate note, I send appreciation to UNFPA, to the Maternal Health Task Force, for supporting this initiative, for supporting the program since we started yesterday. Briefly, maybe I should tell you about CPR, that's the Center for Population and Reproductive Health, which came to be about 10 years ago, roughly, under the partnership of the Federal Ministry of Health, the University of Ibadan, and the Gates Institute at Johns Hopkins University. And it was meant to respond to some of the needs which we are still discussing today, as recognized within Nigeria, which is strengthening the capacity for programming for reproductive health, especially maternal and newborn health in Nigeria. Through capacity building, through project management, mentoring, and conducting bilateral partnership translational research. Now, since yesterday, a passionate cohort of about 50 stakeholders in MNCH, including senior government officials at federal and state level, trainers and practitioners, development partners, NGOs, both local and international. Our traditional rulers were also not left out, and we have representatives of the media. We engaged in a very robust brainstorming and thought-provoking and sometimes even challenging discussion on national challenges in mitigating against a rapid improvement and advancing the health of status of women and children in Nigeria. Now, we had plenary presentations by experts. We had roundtable discussions which were moderated by members on identified themes, followed by an engaged question and answer session, reminding ourselves of the enormity of the burden of maternal mortality, which currently stands at about 576 per 100,000 live births, which to us is only a token achievement or reduction from the level of 800 per 100,000 live births in 2003. Painfully, Nigeria's population is only about 2% of world population, but we contribute about 10% of the maternal mortality. This is not something that is very painful, because we would rather like to show leadership in things like how we control and confront Ebola, for instance. Those are the sort of things that we're working towards. Therefore, we looked at why this situation has been, which include low demand for services, including hospital deliveries, which stands at 38% of all deliveries, a low CPR rate of cross rate of 10%, and these two figures have very wide geographic and regional variations. So we know that the same size does not fit all. And so myself and colleagues who moderated the roundtable discussions are therefore set to share with us this one or two key points that evolved from the themes that we discussed yesterday. Nevertheless, let me just rub by you some of the issues I have internalized myself over this dialogue. The first, I think, is that to move forward, we need to improve skilled birth attendance. That came out strongly from the discussions. And it was found that about 80% of reasons why women do not deliver in facilities, as eloquently narrated by Professor Tolorin, who is the country director of JAPIGO in Nigeria, include the baby came too soon. It is actually not necessary. People have the perception it's not necessary to deliver in facilities. You can deliver at home. Health facilities were either too far or there was no transport to get them there on time. And the cost, hospital bill, out-of-pocket expenses were just far too much for majority of these women. So these dragons, as they were, can be slain through a lot of things, which include birth planning, complication readiness, and respectful maternity care services. Really, these are issues looking at demand, accountability, especially from the providers themselves. Now, the poor access and inequity in the quality of services kept resonating during the discussions, and examples were given to illustrate experience gained through, for instance, the NORI project, which is basically on family planning. The NORI project is the Nigerian Urban Reproductive Initiative sponsored by the Gates Foundation. And this was shared by the country team leader, Dr. Moji Odeku. The concerns of the poor, the underserved, and the marginalized in rural area, in rural populations, we thought could be addressed through engaging traditional and community-driven structures, which are already in place, through which reproductive health and maternal and newborn child health services can actually be expanded to the remote areas of the country. And these platforms are available if they are explored and taken advantage of. Alhaji Umar Jabi, who occupies a very sensitive position of representing the SALT and non-RH issues, echoed this sentiment. But it was Professor Suzu, the president of the Public Health Professionals of Nigeria, that's an organization the equivalent of AFA in America, that later on this, profiling the deployment of community midwifery services, where midwives are, take charge of selected, defined communities, and they know all the women in those communities. They follow them up when they are pregnant, ensuring that they seek services, they attend antenatal clinics, they receive the best quality of service that are available, and when they are not seeing consulting, they can follow them up at home. These midwifery, community midwifery services could be overseen by medical officers of health, who are often family physicians, who can perform skills that far go beyond what the midwife can do. Now, before I hand the baton to group moderators, it is also pertinent for me to share some of the government efforts at addressing some of the issues that were raised. I'm sure that some of our colleagues are from the ministry may add on to this, and especially issues of poor access, inequity, cost, and quality of care through the Midwives Service Scheme, which was established by government to provide quality, highly skilled manpower in rural areas where people do not often want to go and work, by engaging, I think so far, about 3,000 midwives who have been posted to rural areas to provide services. Also, they have the Saving 1 Million Lives project, which is meant to catalyze some of the working interventions that are available. These issues were presented and explained by Dr. Wapada Balami, the head of the Department of Family Health from the Federal Ministry of Health, whose presentation was given by Dr. Kaudi Afolabi, the Director of Reproductive Health in that same department. Now, the gains and the experiences gained from the MSS project was provided by Dr. Okoli, who is the director of that project under the National Primary Healthcare Development Agency. Okay, perhaps I'm taking too much time and talking, but let me also say that the government and fellow participants are 100% agreed that The recommendations that flow out from this dialogue will be applied like fertilizers to improve and increase the fruits of our labor. So it is therefore my pleasure to call on Dr. Kole Shetima, who is the country director of MacArthur Foundation in Nigeria, who is going to moderate the presentations from those who moderate the roundtable discussion. Kole Shetima.
Thank you. Glad to moderate a panel of moderators. Morning, people in New York and those in DC. And of course, I'm not sure to say to all those of us who are following online, maybe from Russia and all kinds of places as well. So we had a distinguished panel yesterday of four panel presentations, and I'm glad to invite Dr. Chris Baroma, who is the Secretary General of the Society of Gynecologists and Obstetricians of Nigeria, to lead the first presentation of the first panel. Please.
Yeah, thank you, Dr. Shetima. Good morning. Yeah, the group that I led handled the issues of quality of care of maternal health services in the country. We came up with many issues, but the most important ones were the fact that the quality of care rendered in most public and private facilities in the countries vary significantly from poor to near excellence. And again, there are inadequate monitoring of quality of care in our healthcare facilities across the country. And this is partly responsible for loss of confidence in our health services and why some of our women refuse to utilize our health facilities. What are the actions? The actions we came up with that could be implemented to mitigate these issues include: one, the creation of dedicated departments and units in the Ministry of Health with motivated staff to enforce standards and quality of care in the country. The enforcement of standards in training institutions through strengthening of regulatory bodies and professional associations.
Oh, we lost.
We can still hear you.
Oh, you can? Oh,
Yeah.
that's great. So, all right.
So I go back again.
Yes, go ahead.
Good morning.
Can I
You can.
You were just
can
before
I
the
interrupt you
standard.
for 1 second? I want the PowerPoint. We can't see you, so I just wanted to make sure
Oh, okay.
on your end that you have the PowerPoint up.
We have the PowerPoint up, and we're on number 2, I believe, on enforcement of standards.
Okay.
Okay.
Perfect. Can't
Thank you.
hear you, but I think I heard you say it's up. Can you still hear us?
We can hear you fine, and we can actually see you fine, too.
Okay, great. So go ahead.
Thank you. Yes, I was talking about the actions that we propose that could help to mitigate these problems. The first one is the creation of dedicated departments and units in the ministries of health across the country, both at the federal and state level, with motivated staff to enforce standards and quality of care. 2, the enforcement of standards. Are you there? Yeah, the enforcement of standards in training institutions through strengthening of regulatory bodies and professional associations. Currently, we have the Medical and Data Council of Nigeria, the Nurse and Midwifery Councils of Nigeria, and other councils that regulate trainings of health workers in this country. We believe that further strengthening of these institutions can help to ensure that the standards of training in the various medical and health institutions are of high standard. We also believe that there should be continued in-service training to update knowledge and skills of our health workers in this country. And this is partly being done by enforcing the annual practicing field renewal through insisting that every health worker should have some level of continuous medical education in the year and have some credits. To encourage staff exchange programs and links with developed centers across the globe. This is already being practiced in some areas of our healthcare, especially in the new trends of assisted reproductive technology, where there is a direct link with some of our facilities and other foreign facilities in developed centers. And these have greatly helped to improve the quality of care rendered in these services. The need to harmonize the existing tools and guidelines and protocols for quality management in the country. We presently have so many guidelines, tools, data collecting, equipments, and so very many organizations use different tools. We believe that we can work better if they are harmonized into a uniform tool that can be used across the countries. We also feel that regular supervisory visits to the health institution will help to ensure that quality is maintained. Budgetary allocation and release and use of funds for purpose of quality improvement. This is one major issue in this country. There are plans, there are budgets are made, but funds sometimes are not released. And even when they are released, sometimes appropriate use are issues. We believe appropriate use of funds could help to ensure that quality are sustained in our health facilities. And lastly, institutionalization of research, including operational research, to identify gaps and propose solutions in terms of quality of care of our facilities. We help greatly in improving quality of care in our health institutions.
Thank you, Chris, for keeping to time. Our next speaker, Dr. Hadiza Galadanchi, who is an associate professor of gynecology at the Aminu Kano Teaching Hospital in Kano, is going to make the next summary presentation.
Thank you very much, Dr. Koleshetima, and good morning all. Well, our group looked at connecting family planning, reproductive health, and maternal health. And we felt the key to this connection is the provision of comprehensive integrated services and packages in all our health facilities. And we feel the public sector and the private sector have to be included in this agenda. Now, as far as the demand side is concerned, we identified one key issue, which is the issue of the family planning messaging, as well as challenges of the user fees. And to address these two problems, we felt for the family planning messages, we need to reframe our family planning message. It needs to be not just for child spacing, as simple as it is, or child limiting, but we should reframe the messages in the context of its overall healthcare benefits. We should be able to reframe it in such a way that it's now a vehicle for actual achievement of the maternal newborn child health continuum of care. And we felt for the elimination of user fees, it shouldn't be just for the family planning commodity itself, but also for the consumables that are necessary in the provision of these family planning commodities. Now, when we looked at the supply side, we felt the issue of skilled healthcare providers, the issue of poor infrastructure, lack of consumables, lack of family planning commodities, as well as frequent stockouts. We feel that all this, in relation to the provision of integrated services, needs to be addressed. And the way to address these issues are, one, by having an integrated package for training, which means if you have training for healthcare workers, they shouldn't just be trained on family planning, or just be trained on reproductive health services, or just be trained on maternal health, but they should have a comprehensive training in such a way that you can have a one-stop clinic where our women can access all these services and quality services. And we also felt that we must have efficient logistics system. Now, efficient logistics system must have a backing of adequate funding and release and utilization of these funds. We also feel that there must be community ownership of actual healthcare provision in the community. Our community leaders and the community should hold the healthcare system accountable for the quality of care that they provide to the community. And we should also be able to have outreach services that can access the remote communities that we cannot really get easily. One or two cross-cutting issues that came up over and over is the issue of funding. Just as we've said, Chris said it and I'm repeating it. We need to have advocacy for increased funding, but not just funding. We also need to have budget lines that are specific for reproductive health in both the federal institutions, federal government, as well as the state and the local government. Because unfortunately, the primary healthcare system is mainly managed by the local government. So we need the local government to also put some money down for reproductive health.
Can you still hear us?
We can hear you and see you fine, yes.
Okay, okay, great, sorry.
This money is not only in terms of budgeting and appropriation, but we feel the money should be released and the money should be used adequately for what it is meant for. So that is very key. And then lastly is the involvement of, the traditional system and the religious leaders. We feel that we need to involve them right from the beginning up to the end. So they need to be integrated into the system. Thank you.
Thank you very much for saving us some few seconds, which we can now pass on to Dr. Professor Degun Patusi, who is the Provost College of Medicine of Obafemi Awolowo University.
Thank you, Dr. Shima. Good morning. My group looked at the issue of social determinants of maternal health. As we do know, social determinants of health talks about the condition in which people are born, grow, work, and age.
Are you still there?
We are.
Yes.
Okay, sorry, we can't see you. We get warning messages. I get
Oh,
confused.
okay. Can you hear us okay, though?
Yeah, we can hear you.
Okay, great.
Yeah, okay, great. Sorry to interrupt. But
That's okay.
So in the context of social determinants of health, our team identified a number of factors, but I'll focus on just two of them. The first is the issue of poverty. Because poverty increases the vulnerability of the poor people to ill health, and on the other hand, it also affects their maternal behavior. As you can see from the DHS data concerning Nigeria, we find that whereas only about 6% of the very poor actually deliver in health facilities, you find more than 80% of the highest wealth quintile delivering there. So poverty is a major issue in terms of maternal behavior. And so we are looking at what are the possible solutions. And we can categorize the solutions into two broad dimensions. The first has to do with the macroeconomic policies that address high poverty rates and also provide social protection to the poor. And the second kind of policy issue has to do with the pro-poor dimensions of policy within the health sector. So I'll talk about the first one, the macroeconomic policy. We feel that to start with, we need to get more jobs created and strengthen the poverty alleviation programs. In that respect, we need to strengthen the
I'm going to assume you're there.
We are.
All right,
We
sorry.
need to strengthen the medium and small scale enterprises, strengthen the partnership with the private sector so that they can create more jobs, and also improve the curricula in the educational sector to become more functional so that people can create more jobs and they can engage in productive jobs. We also feel that we need to improve the infrastructure in many areas, particularly the areas that are most vulnerable, such as our rural areas. And thirdly, look at issues of the environment, where the poor need poor housing and environmental policies that will make them less vulnerable to health problems. So that's the first dimension. The second dimension we spoke about has to do with the policy and practices within the exercise itself. On one hand, we feel that the current program that is addressing the issue of poor through the conditional cash transfer needs to be expanded, and we need to also look at the mechanism to make it sustainable over time. Secondly, there is the issue of free maternal health policy. We believe that if the services are available and made to be free, the poor can access those services more readily. And that should also include the issue of the family planning programs, the free commodities within the family planning sector. We believe strongly that in addition to expanding those programs, we also need to monitor them carefully to be sure that there are no hidden costs to them and that they are being implemented as designed. Thirdly, we feel that there should also be an expansion of the current insurance schemes, particularly the community health insurance, so that we can protect the poor from the challenges of paying for health services. And finally, or maybe 2 dimensions, we also need to build social capital so that the poor can find support within his or her community to help him or her in times of need. And finally, we need to strengthen the whole issue about educating people so that they can avoid certain conditions and practices that can endanger their health. So that's the first issue we dealt with, poverty. The second dimension has to do with the culture and societal values. We believe that this has affects the maternal health practices in several ways. In one of the ways it does is through the negative gender norms. Things, for example, that has to do with violence against women, the low prioritization of girl child education, and the issue of girl child marriage. These are all some of the negative gender norms in Nigeria that we think we need to address as part of the efforts to improve maternal health care. The second dimension is a number of harmful maternal health practices that have their roots
Still there?
Yes.
All right. I'm not going to promise I won't do that again.
All right, the second dimension I was speaking about has to do with the harmful maternal health practices that have their roots in societal values and cultural norms. That, for example, includes delivery at home. We know that today, more than 10% of Nigerian women still deliver at home. In some parts of the country, more than a fifth of women still deliver at home. And this has to do with cultural practices that believe that to prove your womanhood, you need to deliver alone or deliver at home. There's also the whole issue of delivery with unskilled people, either with traditional birth attendants or in spiritual homes. And all these are fueled by the beliefs in the community and society. The other dimension to that is the family planning issue, which my colleague has just talked about. There's some cultural opposition in some quarters, and there is a strong pro-natalistic value within the Nigerian sector. So these are some of the issues we see in the cultural dimension. I feel that to address it, we need to educate people, we need to engage leaders, we need to bring up stronger behavioral change communication program, and also legal provision with regards to child marriage and educational issues. I would like to stop here and pass on back to the moderator. Thank you.
Thank you, Dr. Professor Patusi. It's always difficult to summarize social issues, so I can understand you are struggling to do that. In our advertised program, the next speaker is supposed to be Professor Okonofo of the Ford Foundation. Unfortunately, due to a number of reasons, he can't join us now. He was with us early in the day. But we have the pleasure of having Dr. Oluwagun, who works for the White Ribbon Alliance, but she wants us to advertise also her maternal health task force affiliation as well. So, next to you.
Yeah, actually, if you want to tell folks about your affiliation with Maternal Health Task Force, that would be great too.
Good morning, everybody. I'm Dr. Laugu, as Dr. Shetima rightly said. I'm the project manager for White Ribbon Alliance Nigeria, and I was also part of the 2012-2013 Maternal Health Young Champion, which is a fellowship program handled by the Maternal Health Task Force. Thank you. The group I belong to looked at knowledge gaps and research findings, and we came up with 2 major issues. The first issue is the issue that has to do with data collection, reporting, analysis, and funding. And based on our discussion, we came up with a number of recommendations for this first issue. First, we believe that there is a need to develop a mechanism for collecting maternal health data from all delivery points. And the reason why we say all delivery points is because we know that about 38% it's just about 38% of delivery that takes place in the health facility. More than 60% still take place outside the health facility. And we feel that for us to have accurate data, we need to include both the unorthodox, on the mission houses, the TBAs. We have to look for a way to get our statistics from them too. Then, looking at it, we felt that it might be nice, talking about data collection, because there is challenges with data collection, especially from the local government level. And we felt that if there could be a partnership between the National Youth Service Corps, the reason why we thought of this is because we know that when corporates, National Youth Service Corps is a yearly compulsory system that runs in Nigeria for young graduates. And most times they post them to different geopolitical zones and different states. And many times the federal government pay them, though the state is expected to give them some extra fees. But one thing we feel that since this takes place about 3 or 4 times a year, they send them out, and we have quite a number of them that are paramedics, and they feel that we could leverage on their effort and use them for data collection, that it will go along rather than relying on the local government, which sometimes doesn't pay their staff regularly. Then the other suggestion is that we should institute a mechanism for enforcing regular reporting, both from the public and the private. For the public, we felt that the Federal Ministry of Health will come up with a policy in which if they don't send in their reports, looking at it quarterly, then they shouldn't be given their allocation, and this should be supported by the state. Then looking at the private, we feel that all the privates are lacking behind in submitting data, that if they could tie their annual facility license to the report they submit the previous year, it will help us get more feedback from them. Then during the course of our presentation, the DHIS was presented to us as the tool for collecting data. But we still feel that there is a need to come up with a simpler tool which people can use to send in these data. And the other thing we looked at is that we should always also have a tool which the community can use, looking at community body, which people in the various communities can go to their community leaders' house and input the number of delivery or the number of death. That's that one. Then we thought of the other thing we thought of is how we can promote reporting. And we feel that if these agencies can go into partnership with the telecommunication companies and give them a free platform or through a partnership in which data collectors can send feedback via text message at no cost at all, then it's going to help the process. Then lastly, we sort of we also suggested that it's good to develop and have a costed M&E plan at all levels. And we really appreciate the fact that the National Health Bill has been approved, and we really want them to consider this as part of what they will use the money for. Then the next thing we talk about is the inadequate implementation of research finding and social accountability. We know that there is this big gap between research finding and implementation in Nigeria, and we feel that the way this can be addressed is, one, by involving the government throughout all the research process, both from the planning to the implementation, right to the dissemination. We shouldn't just bring the findings to them at the end and expect them to use it. And we also think that it would be very good if research findings can be articulated into political and developmental implications of benefits. Like that, politicians will see why they need to take ownership of those findings rather than just giving them figures and the statistics, which many times doesn't really make any meaning to them. Then lastly, we talked about social accountability, that's community engagement. And we feel that there is a need to bring in the community into what we do. For the local government level, the World Developmental Committee has been, for the zones in which they are working, they've been very instrumental and they've done quite well. We feel that if we can scale this up to the state and the federal level, it will go a long way. And what do we mean by this? That we need to, number one, we need to enlighten the community further on their rights to health. We need to provide the platform for them to speak. And we also need to support whatever structure they come up with. Thank you.
Thank you, Dr. Ologun. I'm sure our friends at Maternal Health Task Force are proud of the investment that they have made. And now I hand over to Lauren back in DC.
Okay, now we get to hear from John Townsend in response to what we've just heard, which I have to say, you all are very strict there in Nigeria. That was the fastest presentation that we've heard in a long time. You actually didn't use all the time you were supposed to.
Yeah, I think I may have
scared
enforced
them
that a little too much. But if anybody does want to add anything, if anybody got cut off in particular, we do have a couple extra minutes. And again, thank you for abiding by what I had asked for. I didn't expect you to, and that is why we have a few extra minutes. So if anybody wants to add anything before we hear from John.
I think one issue that also kept on coming, although Professor Fatusi mentioned it, is actually really emphasizing on the importance of the girl-child education. I think we don't need to overemphasize that, but all across all the themes, I think all of us brought out that issue as one thing that needs to be tackled. Probably the way we can is ensuring that our government really enforce the universal, basic, education for all. And this, we feel, is the responsibility of the federal government, is the responsibility of the state, as well as the responsibility of the community. But overall, is also the responsibility of our traditional system and our religious leaders. They need to go out and really emphasize how, really investing on girl-child education can actually turn around our maternal health statistics.
Yeah, I also want to add the legal issues involved in as a right, health as a right, human right actually, that until the National Health Act was passed, was assented to by Mr. President, which was only a week ago, the health policy in the country, as our legal lady, the president of FIDA is a federation of...
It's a federation of...
Okay, thank you.
I don't know if they heard that.
FIDA is International Federation of Female Lawyers. The president in Nigeria did say that until this act came to be a week ago, the policies were, the good benefits of health in Nigeria were just wishes from the policy. And that was not strong enough to help the community members to insist on quality care, to demand accountability from providers, and to be able to have a say when things are going wrong within their communities. But with the Health Act now, National Health Act, that has strengthened them, and you can demand, if you are not happy with the services received from some professionals, communities can make a case for them. And I think it also strengthens or forces the hands of the various tiers of government to cede a certain proportion of their money compulsorily for health programs and to present services, quality services to Nigerians. I think that is very good. And people now, because let's face it, what has always happened is people feel that whatever you get from the facility is like, a help. It shouldn't be. It should be your right. So even when delayed services are provided, and whether even the patient survives or sometimes even dies, they still feel obliged to say thank you to the providers without looking at the delays that have happened that may have contributed to morbidity or even to mortality.
Okay, let me assert my authority as the moderator to hand over back to Lauren once again.
Okay, thank you very much. John, please.
Well, great. Thank you very much for your insightful remarks and summary of the dialogue on national challenges. There's no lack of expertise in Nigeria, and certainly no lack of insightful analysis about the challenges that are faced there. There are a few things that weren't mentioned in the introduction that may have some bearing on how we think about the recommendations. Issues of scale and diversity were referred to, but often weren't talked about explicitly. We often see initiatives that are very attractive and promising in one state, but don't get to a scale to benefit actually indicators at either the state, much less the federal level. In a country with 168 million people, 36 federated states, over 750 local government authorities, moving things to scale, obviously, is a challenge. Half the population is urban, but of that population, only 75% have access to water and probably about 60% to sanitary facilities. So the challenges of getting services of quality to people is really an issue. Things as perhaps as simple as vaccination, where we're just trying to get services out to that we know how to do in most countries, is a challenge. Vaccination for BCG, which is pretty simple, 40 days after birth, is only 60% in the country. We have some other things that make it difficult, as well as some other things that maybe give us some opportunities. The prevalence of FGM is 27%, which leads to one of the challenges of maternal morbidity and mortality, which is obstructed labor. 28% of women have children before the age of 18. So issues of maturity, child marriage, that lead to health consequences. On the other hand, there are 68 cell phones for every 100 persons in Nigeria. That's remarkable, given the fact that getting vaccines to people that we know save lives is difficult, but getting cell phones to people doesn't seem to be such a terrific issue. I think the dialogue has done three things. First, it's provided us, I think, with a vision, not for this year or next year, but really a vision we should hold true to 2030. This should be part of our commitment to Sustainable Development Goals. It also talks about our aspirations. Regardless of whether some of these issues are articulated as goals in the Sustainable Development Framework, we should have aspirations about the recognition of autonomy, community responsibility, and national accountability for the welfare of citizens, and particularly those who are most vulnerable. This is a set of aspirations that I think are highly valuable and well articulated. In some way, within the continuum of calls for action, ICPD, Beijing, the African Union, as well as the sign-on of Nigeria and Family Planning 2020, this really is a call to action. In some ways, this call to action has to be more about progress towards universal health coverage than simply addressing the direct determinants of maternal deaths. I think we have to think about it in a larger level to see benefits at the more explicit level. The dialogue involved diverse stakeholders, which was terrific. It was great to hear people from the ministry, from universities, from civil society, the reference to religious and traditional leaders. This all makes sense, and it's a requirement, I think, to make progress. The cumbersome issues of increasing coverage, quality, looking at cost, and looking at infrastructure are profound, not only in the North, but in many places in the South. I think I won't comment too much on the individual recommendations because there's little to debate about their value. The question is how. How, in fact, do we do this? What are the mechanisms that we will use that are different than the mechanisms we've tried and found wanting in the last 5 years? There are a few things that we may want to break down some of this analysis, and I think the discussion did it very well. There are kind of 4 different levels that I'd like to just raise people's attention to. The structural ones, which were mentioned, and those are important because we actually have to deal with a population where 54% of the families are living on less than $1.25 a day. That the level of literacy is relatively low, although kids are going to primary school. That's a good sign. Boys are benefiting somewhat more than girls in terms of literacy, and that remains a problem, but that's a symptom of the underlying issue of recognition of the rights of girls. We have weak governance, and that may be a legal issue. It may be an issue of lack of accountability. It may be an issue of the uncertainty of the role of government relative to private sector and civil society in the exchange of goods, services, and information. In every indicator that we saw, there are huge differences by wealth quintile and urban and rural. The wealthy in Nigeria do about as well as the wealthy in India or the wealthy in UK. Those who are poor probably do worse, and the difference between them is enormous, and I think it's also growing. And that's a problem that we have to, I think, call out and make explicit, so that equity is part of any solution that we call for. Hiring 4,000 midwives, sending them out and not paying them, and expecting women to provide voluntary service is not a solution to any of the problems that were identified.
Exactly.
The second issue has to do with financial. In a country that has largely financed government through oil reserves, the cost of a barrel of oil going from 120 to 60 is not good news. On the other hand, you could say that the people at the community level really never benefited from that money, and they had to pay themselves fees for services and so on. So their experience in a public sector facility was not that different from a private sector facility. They paid for all the services they got. And we can't necessarily blame the providers. This is a context around which providers can be seen as survivors or victims of a system that doesn't provide the support. There's only 2% of national income that goes, national accounts that go to health. National accounts aren't very clear, but 2% is probably a good estimate, and about 5% of GNP is spent on health. And one question is that a good investment given the quality of the health care that was referred to? Reducing fees may be a useful and popular call, as it has been in many countries, but without making that call without clarity about how, in fact, what is the cost of providing good quality, what is the cost of providing human resources at the level that are required to actually make a difference, and what is the cost of ensuring quality at the level, the standard that is desired, is of little help. I think we really need to deal with the financial issue here. In terms of programmatic, I mean, I think the world was pretty impressed with the way that Nigeria handled the Ebola crisis. I think there's been innovations that have been adopted by states, whether it's health insurance funds that seem to be getting reasonable coverage and growing over time with funding from the Dutch, or it's a program in Ondo State that begins to look at the different delays and really focuses on those with good leadership and governance. I think programmatically there's a history and capacity of doing things, and we have to figure out what is the disconnect between leadership that takes these on, demonstrates the possible, the feasible, and the benefits of concerted action, but kind of loses steam in the face of these structural challenges. Local government authorities in many countries have been the source of innovation. In India, we see municipalities doing often better than states. We see local political leadership taking on not only maternal health, but preserving the health of its people so they can offer an economic opportunity to their families and communities. The engagement of women in the workforce, alternatives to motherhood for those women who would like to choose that option, are important ways of which innovation comes into systems. Currently, the total fertility is 6 per woman, and it's down very slightly, but not much. The fact that women don't participate at the level in generally, although we can see from this picture, there's nothing more powerful than a Nigerian woman in any setting. So it's something about scale and the range of this that we have to figure out how those innovations get out. Rotary Club has been doing something interesting using civil leaders who are often heads of hospitals and heads of private companies, and using that social capital as a way to expand services. And I think they've been doing a good job even on family planning, where they've understood the consequences of short birth intervals on maternal death and disability. For every death, we know there's 15 to 30 cases of morbidity, and morbidity is one of the problems that drives families back into poverty if they're having to pay for these services. In some ways, much more than a maternal death might. I think the biggest challenges, really, and maybe the topic for the discussion that we will have is, okay, the guideposts are clear, the analysis is pristine, the articulation of our vision and aspirations is explicit. What is it that we have to do to deal with those structural, financial, programmatic, and lack of uptake of innovations that have demonstrated to be feasible? What do Nigerians have to do to call out rights as a framework, good business practices as a way of demonstrating good governance, and impacts that we all would like to see? The World Bank has talked about performance-based financing. They've also talked about the demographic dividend, but it's clear that Nigeria won't benefit from a demographic dividend unless two critical things happen. One, the age structure begins to change by having smaller families, and then the young people who are there are given opportunities with jobs and a workforce that offers them the opportunity of a better life not only for themselves but their families and communities. Thank you very much for this really insightful discussion. I would love to see the parts of the analysis that you weren't able to share in those brief slides. But this is a terrific opportunity for us to talk about this in the context not only of maternal health change, but universal health coverage. What do we need to do? Thank you.
Thank you, John. I'll hand it back now to Nigeria for a response.
So the panelists, either of you, anybody wants to make any comments in response to John, feel free.
Yeah. The panelists.
You can do it.
Yeah. Well, okay, John, thank you for your very great comments. You had very great comments that should keep us thinking of how to improve what we are doing or the way we are thinking through. My main comment is on the aspect of poverty, which, of course, Segun Fatusi mentioned earlier on, and it's been compounded by issue of spending from government under the Midwives Service Scheme and the SHOP through cash, conditional cash transfer. And these are things that we feel are generally difficult to sustain for a long time. There may be a short-term thing that you can try out, but maintaining it over the years, over the time, may pose a very great challenge. And so, when these projects are conceptualized, I think one of the great things we should be thinking about is to look at their sustainability. Now they're here, and the National Health Insurance Scheme has started. But the people required most, the underserved, the people in the communities, are not benefiting because, number one, they are poor. The community aspect of the health insurance scheme is just being established, I believe, and it's not even functional yet. But they require the more because they cannot even pay for the services. And if communities are better involved in the way the structures of health system in their communities are, it may be better because I remember for education in the past, schools were very much involved. For education, communities were very much involved. And the communities taxed themselves, contributed money, established the schools, built the structures, sent teachers for training, paid their salaries regularly, monitored what they were doing, and they demanded accountability. If children were not passing in any particular school the statutory exams, such teachers are laid off, and better ones are engaged. I think that if people are made to understand that part of their responsibility is also to look after their health, that the individuals are the primary producers of health. Government effort, the ministries of health, and all the agencies are just to help. And if they are so convinced and a shift in their understanding of what health is, and we should provide it, I think they'll be able to contribute more. Really, there have been instances where people had money in their pockets, and they were listed for, say, cesarean section, and they say, oh no, I don't have money, maybe the husband is not there, and in the end, maybe they don't get a C-section and die, and they still find money in their pockets. So again, the orientation is very important, and community understanding.
You want to say something?
Yeah.
Okay.
Thank you. Let me just build on that. I think for me, fundamentally, it all revolves about educating the people and building their capacity. The health figure, the maternal health situation will not change if governance doesn't change. And for governance to change, you need to educate people to start with selecting the right set of leaders. I think that is a base you need to go back to. If you can build the capacity of the people to make the correct choices, to demand accountability, to demand their rights, we'll begin to get a turning point in this whole affair about governance and about health. And next to that is the whole issue about monitoring performances of the health sector elements and tying performances to payments, so that you are not just funding facilities and not just funding programs, but you are assessing them, you are monitoring them carefully and continuously, and therefore you can tie their performance to further incentives and such activities.
Great. I don't know if anybody wants to add from the panelists. Adisa, do you want to say something?
Yes, I think John, mentioned the issue of, there's so many programs that have really demonstrated, the importance and the improvement of maternal health. But the problem is that we don't really translate these findings into actually scaling up to the various hospitals and states, and we're such a huge country. Okay. Now, for example, the issue of the integration, there are so many projects that have actually shown that if you give an integrated package whereby a woman can get into a one-stop shop to get her family planning products, to be able to take care of herself there when she's pregnant, and to be able to have all the problems sorted out as a woman. Most of the time there is a huge increase in uptake of antenatal care, there will be huge intake in delivery services, and huge intake in family planning commodities, because these women become happy with the system. So we need to scale up, we need to make sure that these researches that have shown that they are effective are actually scaled up to the rest of the states and to the rest of the country. We have the issue of the quality assurance that was mentioned by the first group. If we don't improve the quality of care that we provide in our healthcare system, women will not access services. And for us to do that, we need to have the quality assurance cycle implemented. And we have shown by various, by studies and by programs such as the Quality Assurance Program of International, have showed clearly that if you monitor what people do in a healthcare system, you improve the structure, you improve the process, and then at the end of the day, you collect data, and you get back this data back to the system so that they will know how they are doing and they can assess themselves. I think this greatly improves our maternal health statistics. Now, if we have shown this in 1, 2, 3 states, then it becomes paramount that we must scale up to all the other states. And if we have shown it in 1, 2, 3 local governments, we have to scale up in all the 700 local governments. So there is need for us to identify the key findings or projects that have really worked in Nigeria, and then we need to scale up to a country level, not only to a local government level or a state level, but to a country level. We have a state in Nigeria like Ondo State that have shown great improvement in their maternal statistics. What have they done to achieve this? And if we have been able to find out these good practices, then we should be able to scale it up to the other states, not just commenting them and then just forgetting about it. We need to scale it up to the other states.
Yes. Just to reemphasize this fact, John did mention that it's not just good enough to engage almost 4,000 health workers, send them to the rural areas and refuse to pay them. I think those are the issues we are really talking about our health system. We have good plans, good ideas. We start good ideas, but we never sustain them. I think those are the issues. Sustaining good programs that are working. For example, the program you mentioned is one program that Nigeria has been highly rated. We've received different awards all over the globally. We've been, we receive awards for those programs, but unfortunately, it's not being sustained. And this is one program that will have had real positive impacts in our health sector, especially as related to maternal health. So I agree with you that sustenance of programs that are working is a major issue that we should try to emphasize in this country.
Great. Dr. Logan.
Yeah, I just want to ask what they've said so far. Earlier in the day when we were talking, Dr. Deku presented something about health system to us. And I think that's another dimension we need to look at things from. Most times in Nigeria, when you talk of health system, people just think of the health facility alone. As we said, we need to think outside the box to bring everybody in. And to also realize that health actually starts from the family and not just at the health facility, which is more or less the stop point. So there is a need to reorient people generally that health is everybody's business. It's not the government's business, and it's not the partner's business. It's also the community business. So that's all I want to.
Okay. Thank you so much.
Excellent.
I think before we open up to the questions and answers with our audience here, I'd like to invite John to respond to your response.
There was a comment I think you just made, someone made, that it was that we ought to look at these innovations. How in fact did they have this effect? Kole could tell you about the work that was supported by the MacArthur Foundation and the University in Kaduna in support with traditional religious leaders in Kano. They were able to both demonstrate that you could reduce maternal mortality in facilities. You could spare up nurses' time for other services, empty out the eclampsia wards. You could feasibly provide this service at district hospitals, not only tertiary hospitals, and you could train nurses to do this. Somehow figuring out, I mean, it's a remarkable achievement in a relatively short time to do that on a relatively narrow topic. It wasn't a health system change, but the articulation was there between research, expansion of coverage of services, and quickly into a sustainable model. I think whether it's a health insurance scheme or some scheme to address a specific cause of maternal mortality, figuring out what are those articulations between what we learn and then what we do at scale, I think would be very helpful, I think, for our Nigerian community to figure that out, not only for themselves, but for other countries in the region that will be challenged by the same type of effort. Ethiopia is taking things to scale. India is taking the things to scale. Pro-poverty programs and cash transfer experiences are found in Mexico, elsewhere. Figuring out how do we get that at a scale and move from demonstration to financing and actually at a scale that benefits large numbers of people is really what we have to focus on, I think, the next couple of years. Thank you.
All right. Thank you so much. I think we'll open it up now to questions from the audience. I'll take a few questions to start. Does anybody want to start us off? Okay, one in the back there. Just please a reminder to state your name and affiliation.
Good morning, everyone. My name is Adama Odefa from Voice of America and also AIT, African Independent Television. Hello, people in Nigeria. I'm also Nigerian. Can you hear me? Back home?
Yeah.
Okay.
We can hear you.
And I do know a lot of you. I have worked with a lot of you on maternal issues and issues of health because I'm a health advocate back home. Just a few things I want to mention. In all the discussions, I didn't get to hear much about involving or including the press, the media in maternal health. I think it's a big... Yes, you're there, but in the plans and in everything, I'm not hearing much about including the media. I think it's very important to include and closely involve the media. I think they have a big role to play. And I know it's not so easy because media is sort of expensive in Nigeria. The dynamics are different. So I think we could expand and have programs for the media. And I'm happy to tell you that I know for a fact that VOA is interested in starting a program for journalists and media people in Nigeria over maternal health. Then the second thing I want to say is how do we establish regular inspections and accountability for private maternal caregivers? Because I've heard so many stories of women who lose their lives in childbirth in this day and age, not because they're poor, but because they went somewhere and they do whatever they want to do, and there's no accountability for mistakes or for negligence. There's too much loopholes, and people get away with a lot of things back home. So how do we get these people to become more accountable to these women's families when, out of their own negligence, women lose their lives in childbirth? And another thing is, you're talking about free maternal care. I know from experience that when healthcare gets free, or anything, education, healthcare back home, that means the quality really drops and becomes very, very poor. So how will you strike a balance between free and quality? Because when it's free, then no one is really paying as much attention, and no one is really investing that much money in quality. So those are my concerns around maternal health in Nigeria.
Thank you very much. Are there any other questions, or should we start with those three? Oh, I'm sorry. Go ahead.
I think we have one from Nigeria.
They're going to
Okay,
do one more.
there's
Okay.
one more from here, and then we'll pass it back to you.
Thanks so much for this great presentation. I'm Angie Steen. I'm with the Futures Group, and I was actually just out in Nigeria in October. Futures Group was commissioned by GE Healthcare to do a health sector assessment. GE Healthcare is one of the largest kind of suppliers of medical supplies and equipment, and also does a lot of training of bioengineers and health workers to be able to use their technologies. One of the areas that we looked at was maternal health. And so GE was very interested in understanding the situation of health financing, understanding the economy, understanding issues of accountability. And what we found was that I mean, Nigeria, of course, I mean, with the rebasing of the economy, its economy is equivalent now to Poland. And there is a lot of money coming into the country. The consumable market is about $400 billion, and by 2030 it's projected to be about 1.4 trillion. We also found, however, that NHA, as Dr. Townsend alluded to, the NHA is really showing that only about 7% of health spending, or excuse me, only about 7% of total expenditures go to health, total government expenditures go to health. And there's just really a lack of follow-through in terms of money that's committed by national government for these innovative programs like the Midwives Service Scheme. It's just, it's on paper, but it's not being fully funded. Another issue that we saw is that, for example, the Open Budget Institute, or the Open Budget Index, which looks at transparency in government, it's really lacking and it's getting worse. So in the past 5 years, I think Nigeria, it's gone from 20, it's a scale of 1 to 100, and it's gone from 20 to 16. So there's just that lack of transparency. So it is kind of no wonder then that we're seeing a lot of these good innovative programs are just not being fully funded, particularly when it goes down to the local level.
Thank you so much. Do you want to respond in Nigeria?
Well, it's difficult to respond, but yes, we want to respond, and then there will be questions as well. Yes.
Sure.
What do you want to say?
Thank you. At the risk of overemphasizing some of the points you have made, I think part of this problem goes back to the people and their knowledge. Really, there are regulatory agencies. Just that when things happen in private sector, people don't take them up. They don't stand by their right. Just to give you an example, in Lagos, there is a health facility regulating agency that certifies private providers and monitor what they do. And they also ensure that they have qualified personnel. And when things go wrong, either in private or public, doctors, there's the Medical and Dental Council of Nigeria. There is the Nursing Midwifery Council. And all these bodies are there to ensure that things are done properly. But when people don't stand by their right, when people don't know their right, and people don't call for accountability, things will seem to just go down. So if we improve education, or general education, formal education, informal education, health education, the people will demand their right. And as they demand their right, the health sector providers will also be able, they will need to become more proactive, they become more effective. So I think that a lot of that is strengthening the people, building their capacity to demand their right. The second dimension has to do with the health system itself. If you are talking about taking things to scale, and we depend on federal government, it will never get to scale. And the reason is not because federal government cannot, but because the structure is such that the local government has responsibilities. So we need to go back to the local government itself and look at how do we strengthen it in terms of capacity, in terms of the structure. I've been looking at, for example, somebody has talked about the issue of community midwives. If every local government, if something works in one local government, and every other local government reproduces it, it will be taken to scale overnight. So it is not about a federal-driven agenda. It's an agenda that we need to drive from the local government. Get each local government to become structured, to better structured. We are talking about getting medical officers of health into every local government, and they oversee what happens at that level and so on and so forth. So we need to strengthen the local government system to provide truly a robust and effective health system approach in Nigeria.
Thank you.
Yes, sir.
Yeah.
Chetty.
Okay.
Sorry, sir. I just wanted to comment on the issue of the private health sector. I think also institutionalizing maternal death auditing, I think, will be one way of addressing that problem. We've started doing that in terms of the MDRS program, where maternal death surveillance and reporting is made compulsory for all, the local government, the state, and the federal institutions. Now, this is also being done now as a pilot study. So if we're able to show that it is working, then I think we should be able to scale it up to the national level. Now, part of what Ondo State is doing that is actually leading to the improved healthcare indices is actually the confidential inquiry into maternal death. Every single maternal death in Ondo State, whether it's in the private sector, whether it is in the prayer houses, or whether it's in the teaching hospital, has to be reported. And it's reported within a certain period, and somebody has to be accountable for it. And there will be an investigation so that if they find there is anything that is missing, or there is a health system problem, or it's a human resource problem, or it's a commodity problem, then at least you can identify that problem and address that problem so that it won't happen again. So I think institutionalizing maternal death auditing can be a way of addressing the issue of lack of good care in our hospitals.
Professor Tolori. Thank you very much. My name is Emmanuel Diko Tolori. I'm country director for Japan. I'd like to elaborate on a couple of issues that I think, one that we have talked briefly about and one that we have omitted. I think we all agree that if we really want to reduce maternal mortality in this country, we have to increase skilled-birth attendance. We are currently at 38% nationally and as low as 10% in regions of the country with the highest maternal mortality ratios. And to tackle this, one of the things that Nigeria has recently done is to approve a task shifting and task sharing policy, which will allow for the training of community health extension workers in northern parts of the country to provide life-saving skills. In many PSCs in the north, up to 70% of PSCs don't have any midwives or any doctors, but they all have female and male community health extension workers. And these community health extension workers are not volunteers. They are people who have undergone 3 years of some health technology training. They are in the employment of government, so they are salaried. And therefore, all we need to do is really to give them some skills to be able to provide this kind of services. And I think that if this can be implemented, we will certainly be reaching more people. The other point I want to make is about the importance of family planning. It's been mentioned that family planning will reduce maternal mortality by about 30%. But in our country here, on the national average, we're only at 10% for modern methods. And regionally, it's as low as 3 or 4% in the northern part of the country. And I think that we need to destigmatize family planning. For more than 2 decades, even me, I have talked about the health benefits of family planning, focusing on what it does. Don't have your babies too close, not too many, not too early, and that kind of message. But I think we have to start thinking of the demographic benefits of family planning. Our population growth is exploding faster than our economic growth, and so virtually nothing is is enough in our country. We have inadequate electricity, inadequate water, sanitation is poor. I think we need to begin to consider the demographic benefits of scaling up family planning access in our country. Now, finally, my main issue now is that we have a lot of policies that we have approved in this country. We have a lot of guidelines, but implementation of those approved policies is an issue with us. I'm glad that our president has just recently signed the National Health Bill, which again provides a tremendous opportunity for us to access funds that can be used both for health insurance, infrastructural improvements, as well as procurement of commodities and so on. We are just starting. It was only signed a week ago. I hope that it will not go the same way with many other policies that don't get appropriately implemented. So my question is, why is it that we in this country often have policies that are well thought out and approved, but they don't get implemented? How can are there examples out there for us to learn from on how to ensure that political leaders who are aware of approved policies actually do budget for these policies, release funding for these policies, and take the lead in ensuring that these policies are implemented? Thank you. Lauren, I think we'll go back to you, and then in case there are questions, but also in case there are some ideas around the question that Professor Tolorin asked.
Okay, thank you. I did want to note that I don't think you guys talked about the media and how they can be involved in implementing some of your ideas. So if we want to go back to that at some point, it might be useful. Okay. John and Sarah, do you have any responses that you'd like to make to their questions or their comments?
I think the issue of task shifting and the role of family planning in reducing maternal mortality and morbidity is a real good one. It's doubtful if just calling for family planning for maternal health, if maternal health has less value, that won't be the solution. But figuring out how to help and make those services accessible to people, make explicit the link, and ensure that skilled staff are there. I think the task shifting is clearly an issue that we see with in many countries in the region. It's being done successfully in lots of health systems, including the development of clinical officers in Rwanda who are doing C-sections, CHUs in Ethiopia who are providing implants. There's lots of successful examples, I think, that are happening at scale. Figuring out how that fits in with the Nigeria health scene I think is just being explored now. But I think learning those lessons that are occurring at the state level and the local government level, I think are important to get this at a scale where we'll see a benefit.
Thank you. Do we have any more questions here? Yep. We have a couple up front.
But can we make a response to a question?
Would you like to make a response, or do you want to wait for a couple more questions?
Let's get questions from your
Okay.
side also.
Okay, thank you.
Good morning, Abuja. My name's Tamber Stevenson, and I'm actually a public health nutritionist who just came from Ghana doing training with the medical school students there in nutrition, where Cape Coast is really wanting to scale up to having them prepared as well for not only infectious diseases related to nutrition like Ebola, but also non-communicable diseases as well. My question in all of this conversation around reproductive health, maternal and child health nutrition becomes very much important in this conversation, having done it both here in the U.S. and abroad. And I'm curious where in the scheme of things in terms of policy and programming and also just supporting and making sure that the mother and baby have the proper nutrition in order to allow a proper birth to occur is being supported in any kind by our partners here as well.
Okay, one other question.
Thank you. My name is Anirudh Jain. I'm from Population Council. It was music to my ears to see the first slide on quality of care in maternal health. And I think that's an extremely important issue which has been brought up. I would like to just add a suggestion that in order to also see the effect of improved quality on maternal mortality ratios, we may want to set up women-level record keeping in these health facilities. My experience in Nigeria is like 5 years old when I visited Kano. So at that time, there are about 6 different registers where records for the woman who was coming for delivery were kept. But if they are all linked for each woman as she enters the hospital and until she leaves, whatever the outcome is and whether or not she suffered any life-threatening complications and whether she died or survived, whatever happened, that type of record keeping would be able to create some indicators which will show the effect of improved quality of care on maternal mortality ratios or case fatality ratios. Second point, just a caution about these death audits. In some countries, death audits have negative implications because the health facilities, then they don't want to treat women who may die, and they send them away to other facilities, and so it is create additional problems in terms of quality of care and how to improve their life conditions. Thank you.
Okay, thank you very much. I think there was one more question towards back there.
Good morning. My name is Robert Bernardi. I'm with Apt Associates here in Washington, actually in Bethesda, Maryland. And I have been fortunate enough to be part of a great project in Nigeria called PAS2, funded by the United Kingdom, DFID, which has been working in Nigeria in 5 states at the systems level and working both with the federal ministry as well as the state and local governments. We have been working now to assist over 2,000 facilities at the state levels using the WHO cluster model. And so, which has been very successful. We've been working at the governance level, at the facility level, looking at regulations, looking at commodities, helping to reduce prices for consumers when they purchase drugs. These are successful models that exist in Nigeria now that have been proven to achieve and to reduce maternal deaths. Okay? And I would say that that's going to continue. The British are going to continue this. The new MNCH2 program is going to continue in the north in 6 states. Hopefully, we will see that this is going to continue in spite of the security issues that have affected the north. But what I'm trying to say here is that the models exist, and sometimes we don't hear about it because of the fact that we work for different donors and different organizations. But these programs are sustainable. They're going to continue with the with the participation of the local governments, state governments, and the federal ministries. So I think the models exist, and they've been proven to yield results. My question is, with the passage of the new health bill, what additional resources do our partners in Abuja believe will be made available? I know our project is going to be working with the federal ministries to look at the new mechanisms that are going to have to be set up so that these funds can be made available not only at the federal level but the state level. But I'd like to hear from them as to what they think that the broader future holds now that the National Health Bill has passed. Thank you.
All right, thank you very much. Abuja, would you like to respond?
Yes. So this is Doshi again. I'm going to respond to the question about involving the media. And I can assure you that even at this dialogue, the media, both print and electronic, have a very strong representation, even in this room. So the systems, there have been programs of involving media practitioners, even taking them through orientation training programs so that they are really well engaged and knowledgeable about RH issues. And I must say that they have been contributing very tremendous work towards advancing the health of women and children in Nigeria. The second one is about regular inspection and accountability, especially in private institutions. We actually recognize that, and I think I alluded to this in my early remarks, that one of the things we suggested to government is that there should be a unit, an M&E unit in the ministries that can monitor these private institutions, also ensure that their regular licensing and yearly licensing is tied on to their performance in terms of quality and also return of data of their services. So that is being well thought out through. With regards to free service, I mean, nothing is really free, like you said. Somebody is going to pay for it, whether it's government, which is claiming not to have enough money for the population, like Depot Olorim referred to look after services, water, sanitation, and so on. But with regards to the health bill and additional funding, Depot would like to respond to that, I think.
Yeah, thank you. The National Health Bill is supposed to provide 1% of Nigeria's consolidated revenue fund for primary health care. That 1% will then be divided into different tranches. 50% of it will go to the National Health Insurance to fund the basic minimal health package. 20% of it will be used for procurement of commodities, life-saving commodities. 15% of it will be used for infrastructural improvements. I think 10% is meant for health, human resources for health, training, and mentorship, and supportive supervision, and the remaining 5% is meant for emergency medical treatment. So it's fairly well structured, and it also has a provision to accept funding from donor agencies. So the PSC funding is not just going to be the government's 1%. It allows for receipt of donor funds to have a bigger envelope that will now be distributed as we mentioned. One other good provision in it is that the local governments and the state governments are expected to provide a 25% counterpart funding for any activity that will be funded by the project. So that we will hopefully see government commitment at different levels, providing that monetary support.
Yes. Okay. Just to comment on one of the issues raised with regard to refusal of very ill patients in order to avoid maternal deaths. Yes, this issue actually have been taken care of in recent times in this country. The country, about some 14 months ago, the National Council on Health actually adopted the maternal death review as a system, as one of the systems to review all maternal deaths in the country with the hope of identifying the causes and finding means of avoiding subsequent deaths from such causes. And I can let you know that one of the basic principles of the maternal death review is the no name and no blame principle, which shows that the health worker involved will not be prosecuted because of the death of a woman, so long as there is no obvious criminal intent in such cases. And wherever it is from sources where it was reported across the globe, it shows that it has really worked across the countries. In Africa, even in African countries, West African countries, where maternal death review has been established, it has been found that it worked. People no longer avoid treating very ill patients because they are afraid that such patients will die. And I believe that even in this country, in some establishments where we have started implementing maternal death review, that it is, the report from such sites have shown that it is working. I also want to comment on the issue of multiple records that you alluded to. Yes, because in many facilities in this country, because of multiple partners with vertical programs, they insist on using different records for collecting data from health facilities. So it is not out of place for you to get to the antenatal clinic and you see 6, 7, 8 registers collecting virtually the same information from the worker. And that has really been a problem in many of the health facilities. But we believe that with the recent development of the health management information system, we now have standardized forms of collecting data, and this issue is being addressed. And we are sure that in the very near future, most of these multiple registers will no longer be there in the country.
In the house here, we have one of our traditional rulers, whom I would like to give his own perspective for a few minutes, and then after that, call on the Director of Reproductive Health at the Federal Ministry of Health, who is also in the House, to respond to some of the issues that have been mentioned, at least from government perspective.
Okay, thank you.
Sincerity, yeah.
Good morning, all of you. I'm Sarkin Asalat Sani Umar Jabi, the district head in Sokoto, northern Nigeria. On our far traditional institution, they still remain custodian of the grassroots. Ours, we have bridging gap between service providers and the community. Providers that we are sufficiently informed and effectively mobilized to perform, because we need more capacity building that will be able to improve our knowledge of delivering quality messages to our people. And of course we have been doing, that is why demand is always being created. And then the effort to ensure that we mobilize every member of the community is still on 5 line. We're working with the media house, we're working with the government, we're working with the non-governmental organization to ensure that we deliver messages to community so as to change behavior toward allowing women to access services, ANC, delivery, and as well for natal care. And as well, it's ongoing. So we continue to do that, and we appreciate the commitment of the partners and the government of Nigeria. Thank you.
Dr. Afolabi.
Thank you very much. I'm Dr. Kayode Afolabi, the Director of Reproductive Health, Federal Ministry of Health. From the government side, I'd first like to say that through the Federal Ministry of Health, the federal government of Nigeria is quite very happy for this Abuja policy dialogue that is being organized at this point. At a point where we have all resolved that we need to reposition our country to improve maternal and child health so that we can celebrate the impact with a view to moving towards or achieving MDG 4 and 5. And it is actually the hope of the government for us to have the outputs of this meeting, influencing and enhancing every component of a system, particularly in an intersectoral manner. There are a few comments I would also like to make with this opportunity, and I'll be very brief. On the issue of data collection, the federal government of Nigeria recently has deployed the use of DHIS2, a web-based platform to collect data at a district level. And this will mitigate against the bottlenecks around availability of quality and reliable data. Also, we are leveraging on this platform to integrate human resource and commodity data, which will, of course, enhance us to be able to troubleshoot and make appropriate decisions timely to address some issues. The issue of skilled band attendants, I'm happy Professor Ocholorin talked on tax sharing and tax shifting. And it's been mentioned here today, the role of community midwives. I also like to add to this the fact that the federal government of Nigeria had adopted a new cadre of healthcare worker, which we refer to as community midwife. Their training is quite different from what the traditional staff nurse midwife training receive, because they are straight courses. They have a straight course training of 18 months. And they also have commitment to return to the community where they have been supported for this training for their practice, at least for a specified period of time before they could move out of such area. And we believe that this will largely help to address the issue of human resource for health, particularly in the rural area where the burden is very high. Then on commodity issue, Nigeria is one of the 9 pathfinders countries being supported for UN Commission life-saving commodity, and a lot has also been put in place in this regard, particularly ensuring that these life-saving commodities actually reach the women and children that need them. That is distribution of this life-saving commodity to the last mile, as well as ensuring that they get onto the essential medicine list and in the appropriate portion of the essential medicine list to increase access to this commodity. It's also very important to note the fact that we encourage local production, and this is being supported both by the federal government of Nigeria and partners. We have been able to produce Clexidine gel for cut care of newborn in country. And this makes Nigeria to be the first African country to produce this life-saving commodity, and the second in the world after Nepal. Also, production of dispersible amoxicillin tablet is also achieved recently. These are some of the efforts that I think I should also mention in addition to what have been mentioned. Generally, we are happy, as I said, and we are looking forward to a situation where the outputs of this policy dialogue will enhance policy decision and direction of the government of Nigeria. And I use the opportunity to thank the organizer at this time, the Center for Population and Reproductive Health of the University of Ibadan, and the support they also got from UNFPA and the Wilson Center from Washington is quite appreciated. Thank you very much.
Great. So, Lauren, we have one additional question, and then we can go back to you people. Can you say that? Yeah.
I'm Dr. Adeyinka. I'm standing in for Director and Deputy Director of Planning.
I'm sorry, can you speak up just a little bit?
She's coming to the table now.
Okay.
I'm Dr. Adeyinka. I'm standing in for Director and Deputy Director of Planning. My response is on data recording. As far as Nigeria is concerned, all the tools are already harmonized by all the programs. And in terms of all this complication, the aspect of pregnancy is already devised in the tools and it can even be tracked. And in terms of the community too, there's already a tool on ground to track the delivery within the community. But what we really need is more strengthening strengthening the HMIS at the level of the country. And top of the quality, you're talking about that when there is free delivery, when the healthcare is free, the quality is always dropped because there is increase in demand. And I'm thinking of all this task shifting and task sharing. By increasing the number of midwifery or using the community health workers to be doing the work of the midwifery somehow, it can also make the quality to be maintained instead of being dropped.
Thank you. So Lauren, you want to take over from there?
Sure. John, do you have anything you would like to say before I ask any more questions?
The only thing I'd like to add is maybe with the advent of the new global financing facility, I think, and given the issues of finance that we've talked about, it would probably make sense for Nigeria to engage directly in those discussions about shaping the way finances would come from this new entity. It will focus not only, I think, on potential elements for improving quality, but also procurement and other critical issues for the future of Nigeria. So given the important role that Nigeria will play in health indicators globally over the next 15 years, I just would encourage you to get involved, give your opinion, and shape the way that facility will operate.
I think we have one more question on this side, and then I think we'll have an opportunity for any closing remarks from Abuja and from here. So, one question.
Yeah. Thank you very much. My name is Chinonso Norom. I'm also Nigerian, and I work for Population Action International here in DC. Nice to meet you all, my brothers and sisters, and my former professors. So my question is around stockouts. And I know one of the presentations talked about stockouts as one of the major issues we are facing with respect to addressing the issue of maternal health. But I was just curious, and I'll be curious to learn from you all, if there are any mechanisms in Nigeria to track stockouts at local government and state level. I know that there are several reports on stockouts at the national level, but it's becoming more and more obvious that these things happen at the sub-decentralized level. So I'm curious to learn if there are any mechanisms to track these things there, and how is the federal government or state government or local government actually addressing these issues at the local government or state level. Thank you.
Thank you.
Good. So I think we have...
Sorry,
we
have one add-on to that question, and then we'll hand it back to you. Just 1 second.
Just a minor add-on. I'm Kuhu Maithur from Abt Associates, and I want to go back to the lady from Voice of America about the private health providers. And we at Abt Associates, we have a centrally funded project called SHOPS, Sustainable Health Outcomes to provide improve health outcomes in the private sector. And we have been working. Can you hear?
It is, yeah, it's working.
We have been working to improve the capacity, clinical skills of the private providers. However, we do notice that it's really, really very difficult to monitor their quality of care after we kind of, move back and see how they are providing services. When the project is going on, we do have a system to see how the quality of care is provided for all sorts of healthcare providers that are there within the project system. But we did talk to UNFPA. We sort of went back to HEFAMA. However, there is not a formal sort of a system where you can monitor the quality of care provided by the private providers.
Okay.
Thank you.
All right. I think I think we need to hand it back just to make sure we have enough time for any closing remarks from Abuja. So, Nigeria, would you like to chime in now?
I think we have common up comments from other people, and then we can round it up. Then we'll make it very quick. I'd like to want to talk about the misoprostol you said.
Yeah. Regarding to the stock out, communities themselves, provided they were educated and they provided with the services, life-saving commodities that they can happen to provide within their community. Let me share experience of Sokoto, where we started seeing WHO approve misoprostol for the prevention of postpartum hemorrhage In Sokoto State, some communities start involving into the contribution, monthly contribution from mosques, from social gatherings, to involve into procurement and training and retraining of the volunteer and as well as TBS as a result of higher burden of home delivery using to prevent postpartum hemorrhage. So this commodity, if commodity can be supplied timely by the government, it will continue to mitigate the burden of postpartum hemorrhage in community.
Thank you. And do you want to say something about that as well?
Okay, fine, thank you. My name is Dr. Paul Manyadogo, the Permanent Secretary, Ministry of Health in Kaduna State. I think we've already talked about how to address the problem of stockouts, where states and local governments are encouraged to have budget lines so that they can also contribute in the procurement of these commodities. And not just the FP commodities themselves, but other commodities that are related to the provision of services, because often you have the FP commodities, but those other allied commodities that you require in the provision of such services are not available. So I think the encouragement here is that both the states and the local government should also create budget lines for this procurement. And I think I would want to comment on what the gentleman said with respect to Parts 2. Incidentally, I come from a state that benefited immensely from Parts 2 project, and I want to say that we have prepared ourselves adequately. We've noted all the interventions that we can continue to sustain. First, we looked at creating institutional homes for some of the projects that we found very useful. Today, some of the trainings that Part 2 anchored, we have institutionalized them in some of our training institutions for continuity and sustainability. And I must also say, in order to encourage him, that the systems have been strengthened. When you talk about budgeting, the medium-term sector strategy budgeting is fully domesticated. Previously, we relied on consultants to support us. Today, we do this without the help of any consultant. We're able to come up with execution plans that also help us to look and assess what we have performed. So I think the gentleman should be encouraged that Parts 2 has done a lot, and we are working towards sustaining all the development that Parts 2 left behind. Yesterday, I did mention this 8-pillar interventions of Part 2 in primary healthcare agencies, primary healthcare centers. And I did mention that for any intervention in a primary health center, if we can follow this integrated approach, using the Parts 2 8-pillar approach, then, which has been shown to increase the uptake of services, whether deliveries, whether ANCs, and other services. That way, we should be able to reach more mothers, more children with interventions. So just to encourage you that we are sustaining what Parts 2 left behind. Thank you. And also, with respect to the media, John earlier on talked about equity, scale up, and funding, how we can bridge the gap between the leadership and implementing some of these very good programs. And I think using the Ebola approach, one thing that is very clear where we had this success was the concerted effort in collaboration. Why? Because there was a national sense of emergency and duty. And I think the press can come in this way, raising our sense of perception for the problem of maternal and child health in this country. This, I think, is where the press can come in, change our perception so that we see maternal health as an emergency and a sense of duty for all of us. Thank you.
Mr. Moderator, can you permit me to put in a few words on the issue of stockout? Actually, there is a system in place to track stockout. But you see, there need to be caution in interpreting what we mean by stockout, because most times we do not speak the same language. Stockout could mean that by the time a facility survey is conducted on that particular day, there are no drugs, or there are no that particular drug in stock. It could mean that maybe the past 6 months they have ever had stockout. So interpreting stockout is fraught with some risk. So we need to exercise caution on that. However, it's important to say that there is a system in place, GPRS survey and the rest of them. However, actual consumption data is what is most reliable when we talk of stockout and quantification and procurement planning to mitigate against stockout.
Thank you.
Okay, so Lauren, Sarah, John, and the DC brothers and sisters, we'd like to thank you for sharing your time with us. The last 2 days has been a major experience for us as partners in Nigeria in different from different sectors. And I think we've been able to learn some great lessons that can help us to improve our performance, not just at policy level, even at service level. And I think I'd like to thank Sandeep, who has been very wonderful in encouraging us to put all this together. If you remember, this started before. It was going to be in Abuja, then there was a security issue, we went to Ghana, then we were going to come back. Finally, we're here, and we're happy that you have been participants and supporters in this process. Thank you so much, and I thank all my colleagues in Nigeria, Abuja. Thank you.
Oh, yeah, I just, I know, sorry. Lauren, I just quickly wanted to say, I know that you've thanked UNFPA on the Wilson Center's behalf, as well as MHTF and the Center for Population and Reproductive Health. But I really would be remiss if I didn't tell you all in America who don't know, I'm Sandeep Pathela. I'm the Senior Program Associate with the Maternal Health Initiative at the Wilson Center, and I am just about the luckiest girl in the world right now. I have just spent the last 2 days, and I hope you could tell virtually that I'm sitting here with a room full of movers and shakers around maternal health. I'm sitting here with experts and having real dialogue, really questioning one another about what interventions work, what needs to be scaled up, and I really look forward to coming back to DC, although I'm not looking forward to that flight tonight, but I'm looking forward to coming back and telling you all about this, because I don't think the past 2 hours really could have done justice in terms of the expertise, the moderators, the plenary speakers we've had, the group discussions that have occurred, and the amazing support to put this together that would not have happened without Josu, as well as Bola's assistants and their team at the Center for Population and Reproductive Health. So see you all in a few days in DC, and thanks for letting me get those thanks in.
Oh, of course. Thank you. I think that was a pretty good wrap-up, so we'll leave it at that. But I do want to thank Sarah and John for being with us today, and our U.S. audience for coming in person to be with us. And thank you to all of our friends in Nigeria. It was very wonderful to watch you and listen to you, and we look forward to hearing more about your meeting. All right. Travel safe, Sandeep. Thanks.
Great.